In pediatric liver transplantation by Dr. Jagadeesh Menon. He is an alumnus of Calicut Medical College. He has done his MD Pediatrics and Pediatric Gastro from PGI. He is a member of International Liver Transplant Society. He is a consultant pediatric and gastro and hepatologist at Rela Hospital.
Good evening, ladies and gentlemen. First of all, I would like to thank the IMA of Kannur for giving us this opportunity. So let me straight away go to the topic. I think the scenario of liver transplant in children, I think it is an evolving thing, and it is different from adult because there are a lot of etiologies of liver disease in children. So first of all, I think Dr. Starzl, he is known as the father of liver transplant, who did the first liver transplant, and in 1963 when it was done on a child with biliary atresia. Subsequently, the successful liver transplant was done in 1967. Again, it was done for a liver disease in a child with hepatoblastoma. Statistically, if we see, I think in India, in a year, I think around 3,000 children requires a liver transplant, and hardly around 150 to 200 would actually land up in a liver transplant. That will be the format of my talk. I think acute liver failure in children, it is a scenario, I think it is a bit different from the adult, because encephalopathy, I think we define it with stage 1 when we call it as irritability. This cannot be sometimes applied to kid, because a one-year-old child or a 2-year-old child with fever can be irritable, or if someone has a like an infection somewhere else, they can be actually irritable. So encephalopathy is actually difficult to diagnose in a child, especially in young infant. With respect to that, the pediatric acute liver failure group, in fact, has given this criteria, which takes INR as the single important parameter. A non-correctable INR, which is more than 2, is suggestive of acute liver failure. So the data from India, which says that acute liver failure, the commonest etiology in kids is acute viral hepatitis, commonest being hepatitis A followed by hepatitis E, and the same becomes indication for a liver transplant when they land up in a liver failure. We know this story. So basically Prometheus was subjected to die. The vulture would eat his liver. Every time the vulture comes the next day, the liver will regenerate. So that speaks of the immense regenerative capacity of the liver. I would just brush through this figure. It actually speaks that when the liver volume, we can see in fact, the red thing here is the hepatocyte. So when the number of hepatocyte comes down to 40%, that is the time when the INR actually goes up. And when only one-fourth of the hepatocyte is remaining, that is the point in acute liver failure when the regeneration becomes almost nil, and that becomes an indication for liver transplant. So in acute liver failure in kids, the single most parameter that we see for an indication of liver transplant is INR, which is more than 4. Currently, the outcomes of acute liver failure in the post-transplant period has become better because of better understanding of the disease pathophysiology and better protocols to manage in the ICU care. Recently, there are a lot of kids who can be viral hepatitis negative, Wilson negative, autoimmune hepatitis negative, coming with acute liver failure, and it is now thought that there are monogenic diseases which can lead to acute liver failure, including the NBAS, that is the neuroblastoma-associated sequencing, TALDO, etc. So far, there are case reports, short series which actually says that the outcome is good in these kids. So coming on to the next topic, it's the neonatal cholestasis. I think it is like a total, it's like a book of mysteries. There are hundreds of causes of cholestasis, but the commonest scenario always that we see is an infant who is presenting to us with an alcoholic stool. And for example, this is a child who had a surgery at 90 days of life, subsequently failed to clear the jaundice, and now he has features of decompensation, and we know that it is biliary atresia. So this disease is being increasingly diagnosed, and they can have associated malformation. The recent data, that is, we have done 540 liver transplantation in children at our center. At least 50% was done for biliary atresia. Kasai surgery should be done when the child presents with symptoms ideally less than 60 days, can go up to 90 days. But still, after Kasai surgery, at least 70 to 80% will land up in a liver transplant after 1 to 2 decades, because the process of biliary atresia is not a static process. It is a progressive necroinflammation which goes inside the liver, and Kasai is just a temporary surgery. So when the surgery is done in more than 100 days of age, then the success of Kasai drastically drops down to 5%. So when do you do a transplant in atresia? When the Kasai surgery fails, when they have severe evidence of large varices, actually portal hypertension, evidence of massive spleen ascites, recurrent cholangitis. Biliary atresia is one of the reasons for HCCs in kids. So this is the data from our center, which actually compares a child who has underwent a Kasai surgery, failed that, and who came for a liver transplant, and kids who had underwent a Kasai surgery, who didn't undergo a Kasai surgery. We found out that statistically there is no much difference in their post-transplant outcome. So this is a long-term data that is from Japan actually, which shows a 20-year follow-up in which they have seen the outcome up to 75. So this is the same kid in the post-transplant period. Coming on to the second commonest cause of cholestasis, it is the progressive familial intrahepatic cholestasis, what otherwise we know as PFIC. So that is the second commonest cause of cholestasis, clinical cholestasis, genetic cholestasis, and that requires subsequently a liver transplant. Traditionally, we know that 3 types exist, but because of the genetic analysis and newer immunostains, more types are being detected. Only one thing that is important in the transplant perspective is that in PFIC1, they can have some extrahepatic symptoms which can temporarily worsen the outcome. So sometimes we do this biliary diversion in the post-transplant period so that the steatohepatitis improves, in fact. So this patient actually in the baseline, when we see, so he had a steatohepatitis which went up to, I think the figure D there, which shows more than 90% steatosis, and post-diversion the liver is normal. So we have done, this is a newer type of PFIC which is known as TJP. And we have done 4 children. This is the first time the outcomes in TJP2 is being described ever, and all of these kids actually did well in the post-transplant period without any extrahepatic manifestations. Coming on to the other important cause of cholestasis, whenever a dysmorphic child gives a history of cardiac disorder, or someone who had underwent a cardiac surgery coming with hepatosplenomegaly or features of chronic liver disease, then one of the important possibilities is actually Alagille's syndrome. 1/4 of them would land up in a cirrhosis and may indicate a liver transplant, but the most horrible symptom, like in PFIC, is itching in these kids. So in our experience, actually, we had transplanted 10 patients. Currently, the data stands at 15. All of them are actually doing well in the post-transplant period. Coming on to the other textbook, which is the metabolic disorders. Metabolic means something that we eat getting metabolized, so it can be disorders of protein metabolism, fat metabolism, carbohydrate, or any other metabolic pathway. So in this review, actually, we have divided for the ease of classification 3 types. One is a metabolic defect which leads to a cirrhosis in the liver, leading to a liver transplant. The classical example is Wilson disease. B is something where the enzyme is defective in the liver. Liver is morphologically normal, but manifestations are in the nervous system. The typical example is Crigler-Najjar syndrome. The C type is basically those who have both hepatic and extrahepatic manifestation, which is organic acidemia. Wilson disease, we all know that it is one of the commonest metabolic liver disease in the elderly children, the non-infants. It can have protein manifestations. It can even just present with a fatty liver. It can be just isolated enzymes. They can have extrahepatic manifestation. Wilson in acute liver failure is an emergency, because when we score it with the score, which is known as the Wilson score, if the score is greater than 11, we can see that in the left side of the graph, actually, all of them probably had survived with the supportive care. Once it crosses the 11, this is one of the lines which is actually very important here. When it is more than 11, more than 98% would actually land up in a transplant, or they would die off. Coming on to the another metabolic disease, which we sometimes see in infants presenting with frank rickets, they present with liver cirrhosis, sometimes they come with HCC, sometimes they have like renal tubular acidosis. So this is called as tyrosinemia type 1. There is a drug called NTBC. The availability is quite difficult, and for a month it would take around 2 lakhs for treatment with this drug, and it needs to be started within 28 days of life. So this is our experience like of all the children who underwent a liver transplant for tyrosinemia type 1. The outcomes were actually very good, 100% graft and patient survival in this case. One interesting metabolic liver disease is actually the hyperoxaluria. So in this case, they are present with CKD. Enzyme is just defective in the liver. Once we do the liver transplant, the enzyme is replenished, and subsequently we can save the kidney if we are diagnosing it early. So we have done around 19 children with hyperoxalosis. There are a few indications where you change both kidneys and liver. One is, I told, where it is hyperoxalosis in which you have an end-stage kidney with a liver. Others include congenital hepatic fibrosis with an end-stage kidney, protein C deficiency because the factor is synthesized from the liver, and a hemolytic uremic syndrome. The commonest hepatic tumor in kids is always hepatoblastoma. You stage it with the text staging actually, pre-text staging before chemotherapy, post-text after chemotherapy. Based on the therapeutic response or size reduction, we can decide whether we can offer a surgery, that is a resection, or a liver transplant. The outcomes are excellent in actually hepatoblastomas. So it can be a disease donor liver transplantation, living donor liver transplantation. So I would just skip the slides. I would just highlight this technique that we use at our center, which is known as the auxiliary. Auxiliary means to augment or help. So this is a liver. For example, it is a liver which is damaged now, and we are taking a part of that native liver. The grapes which is going from the other side is the donor liver. It is attached to the recipient, and so whatever the remnant liver is there, I think sometimes in acute liver failure when we do it, the remnant liver may regenerate. The importance is if the native liver regenerates, there is a chance that the child can be weaned off immunosuppression. So that is the most important aspect of an auxiliary liver transplant. They may not be on a lifelong immunosuppression. It is also done in conditions like Crigler-Najjar syndrome. So this is a kid who landed from Oman with a hepatitis E-induced acute liver failure. He did very well in the post-transplant period, and this is what I was explaining, that subsequently this is the transplanted liver. Over a span of years, the native liver has grown back and the auxiliary graft has remained like a scar. So this is a natural phenomenon that happens in the body. So there are a few unique scenarios in which you offer liver transplant in kids. Crigler-Najjar syndrome, Neuro-Wilson disease, organic acidemia. The other conditions I've already explained, protein C and hemolytic uremic syndrome. Hemophilia A, because the factor is actually synthesized from the liver. When not to go ahead, that is very important, because the choice of acute liver, like the liver disease, whom to choose is very important. A 4-month infant was referred to us for liver transplant. The kid had frank features of cirrhosis. So incidentally, we saw this X-ray, which was showing some calcification on both sides of the spine, if you can appreciate. So with respect to this, one possibility was Wolman disease, because we know that it can present with adrenal calcifications. We did a bone marrow which was showing a storage cell, and the enzyme assay was highly suggestive of Wolman. Wolman disease is a contraindication because the liver will work, but subsequently 2 issues will happen. The cells again will infiltrate the liver and cause secondary damage to the liver. Second is the neurological progression is independent of the liver disease, so they would probably die because of the acute life-threatening events due to aspiration pneumonia, etc. There are active contraindication, disseminated malignancy, active uncontrolled sepsis, severe cardiac and lung dysfunction, mitochondrial disorders with extrahepatic manifestations, HLH, Niemann-Pick and Wolman disease are absolute contraindication. So there are transplant complications that may happen. It can be due to either medications or surgical. Can be renal impairment. Sometimes they develop rejection. There can be post-transplant lymphoproliferation. Sometimes the disease can recur, and sometimes autoimmune disease can happen. So it is like the liver transplantation is always like a teamwork that we do. So without touching COVID, it will be not justified in this era. So there is a meta-analysis which actually shows that the outcome of liver transplant recipients were not worse during the COVID era. So this is an interesting analysis that we did at our center. So we compared the cohort of patients in the same timeline during the first wave of COVID and the last year where it was COVID-free. We could see that the outcomes were strikingly better. That's why the title, which is called as a serendipitous silver lining, because the mortality was 0% during COVID time and the sepsis was 50% lesser because of increased use of more use of PPEs, decreased patient shifting time and all those things. So just like brushing through one or two scenario, this is a kid who was referred from Uzbekistan with cholestasis and hepatosplenomegaly for a liver transplant. Subsequently, biopsy, skin biopsy, the child actually, we can see that there are some rashes over the scalp. Biopsy was done, which was suggestive of Langerhans histiocytosis. So this is one of the causes of end-stage liver disease in children less than 3 years of age. So we usually treat them with chemotherapy, low hepatotoxic chemotherapy, and subsequently we will offer a liver transplant. This is an 11-year-old boy coming from Chandigarh. He was having liver disease from early infancy, from history. We did the genetic analysis, which was showing a defect in the very long chain fatty acid. So in the post-transplant period, we can see that even the dysmorphism, the exophthalmos is completely resolved because the metabolism of fat became normal here. So this is the first patient ever to undergo a liver transplant in Zellweger syndrome. So this is the scenario of a 5-day newborn with an acute liver failure. Newborn acute liver failure, we always know sepsis can be a confounding factor. There can be this disease called as neonatal hemochromatosis. This is the youngest child ever to undergo a liver transplant, and he is our chairman actually, Professor Rela, who has done this surgery at King's College. We can see that this kid has grown up to a lawyer now. She is a practicing lawyer in Ireland. She is now 22 years old. Concluding my talk, ladies and gentlemen, liver disease in kids is a wide spectrum. Indications and contraindications are equally important. Outcomes have dramatically improved over the recent years, and weaning of immune suppression needs more solid evidence for implementation. Thank you so much.